because cyclophosphamide and indeed rituximab may suppress the formation of antiphospholipid antibodies, which we think are directly relevant to the phenomenon of thrombophilia. Raynaud's phenomenon then, calcium channel antagonists, always disappointing. Nitrate patches can have a little. Together, they may have some impact. Sildenafil, phosphodiesterase inhibitors. Sildenafil is the only one which seems to work in these patients who have vasospastic disease. Whether it's accessible to you, I can't say. Pasantin, on the other hand, is a disappointment in dealing with peripheral vasospasm. Its main role is dealing with pulmonary hypertension and vasospasm of the pulmonary arteries. But sildenafil is proving extremely attractive in treating these patients. So we're looking here in this group mainly at patients with scleroderma, mixed connective tissue disease, and rather less frequently lupus. And it does occur in lupus. So in this study, which was published a couple of years ago, 1.4% of a series of almost 500 lupus patients had episodes of digital ischemia, young patients like this, patient with lupus. And you can see the majority of them actually had antiphospholipid antibodies or the lupus anticoagulant. And the frequency with which vasculitis accounted for this phenomenon was simply not quantified. So whenever you encounter this phenomenon in lupus, it's most often due to prothrombophilia. So the call always goes out, does this patient have vasculitis? And although they might have, it's more likely that the relevant pathology is a prothrombotic element to their disease. So this comes from that paper that I just quoted. These are the recommended treatments, which I've already touched on, as a general approach to digital ischemia. Continuous infusion of iloprost, epoprostenol, low molecular weight heparin, warfarin, once the diagnosis of antiphospholipid antibodies has been established. Intravenous methylprednisolone was recommended in that study. Again, I speak about cyclophosphamide and rituximab because immunosuppression may make a difference to the generation of the antibodies. It's a little speculative. But I think that since preservation of what viable tissue there may be is so important, it's worth throwing everything at this particular problem. Here's a patient with vasospastic disease who has lupus, with clear evidence of previous digital ischemia with loss of pulp. There's another patient who's lost the end of the finger as a result of previous digital ischemia, just severe Raynaud's. Here's another patient who's had previous digital ischemia. What I want to draw to your attention, however, is the fact that all of these patients have not lost their fingers. Sorry, we've gone right back to where we were. But if you can, keep the surgeons out of your hair. Amputation should be avoided because it's amazing how much tissue can be preserved by early treatment along the lines suggested. Early vasodilatation, embolectomy, of course, that's where you need to involve the surgeon. But for the conditions that you might know as rheumatologists, antiphospholipid syndrome, severe vasospastic disease, and often when you don't know what the diagnosis is, you should try to avoid surgeons amputating. Always a temptation, because if you wait long enough, it is amazing how much tissue can be preserved. And healing can take place too. So where a finger may appear totally black over a period of weeks or months, it may return to almost normal. It may look as though at presentation it's beyond salvation. They're completely black. So these are other things that you might want to consider for Raynaud's phenomenon and vasculitis. And I haven't touched on cancer, but the management of the digital ischemia is the same initially, no matter what the cause. But cancer, all cancers, can produce digital ischemia, and these are some of the mechanisms which have been suggested. There's no doubt that antiphospholipid antibodies may be generated in some cancers, and there may be vasospasm. But I think for most of the cases, you can't find a cause, it just happens. Furthermore, cancer probably accounts for many of those cases that we can't diagnose. Like this patient, oddly enough, this was a man who had a previous history of polymyalgia rheumatica, who was on corticosteroids when he presented with these toes. All the investigations that we did were normal. We weren't able to demonstrate any vaso-occlusive disease, vasospastic disease, and he certainly had no evidence of a connective tissue disease. And these recovered completely with treatment. Within 4 weeks, he was walking around with only some digital ulcers, and within 6 months, he was normal, back to normal. But a year after his presentation, he developed weight loss, and his chest X-ray showed that he actually had a bronchial carcinoma. And I have no doubt at all that this presentation was related to his underlying malignancy, which was occult at the time of his presentation. This is another case, a cancer case. So it can happen this way.